Hip bursitis is a clinical condition characterized by pain on the lateral aspect of the hip. As a disease entity, it's more of a symptom rather than the primary pathology. The underlying pathology is, in most cases, microtears of the gluteus medius tendon, or sometimes frank tears within that tendon. Inflammation within that tear then manifests as pain on the lateral aspect of the hip. It's diagnosed clinically. The surface marking is the greater trochanter, and palpable tenderness over the greater trochanter results in discomfort. Patients typically complain of pain over that area, pain lying on that side, or as the condition progresses, they get more constant pain. The diagnosis is usually clinical but can be augmented with imaging, and the imaging features or the imaging modality would either be MRI or ultrasound. So the ultrasound is operator dependent, but they would report fluid collection over the greater trochanter or occasionally inflammation within the soft tissues. Similarly, on an MRI scan, there would be increased signal on certain sequences within the MRI scan in keeping with inflammation or edema over the greater trochanter. The majority of patients with trochanteric bursitis are managed non-operatively, and the non-operative management consists of activity modification, weight control, oral pain medication, and strengthening up of the weak muscle, that is the hip abductors or gluteus medius. Local injections of local anesthetic and steroid have a role to reduce the pain to allow the patients to rehabilitation being the mainstay of their management. In those few patients who are refractory to non-operative management, surgical repair of the damaged tendon has a role. So femoral acetabular impingement is a condition whereby the femur impinges against the acetabulum. It occurs for a number of reasons, either a femoral deformity, which is typically described as cam impingement, an acetabular deformity, which would be described as pincer impingement, or a combination of the two. And it also occurs in those patients who are hyperlax, so they would have a supraphysiological range of motion and would be able to impinge one against the other. A large number of patients have imaging features of femoral acetabular impingement without having the symptoms. In those patients who develop symptoms, they are said to have the condition of femoral acetabular impingement. The patients would typically describe pain about the hip. The typical description is the C sign, where the patient places one finger over the lateral hip and one finger into the groin and says that their pain is deep-seated. Most of these patients would typically be sporty, GA players, soccer players and the like. The mainstay of management of this is non-operative, consisting of modifying the activity, changing their training regime, possibly engaging a physiotherapist, watching weight where appropriate, and pain medication. In the context where it doesn't settle despite the non-operative management, then referral for surgical opinion is reasonable. So when patients have failed a non-operative course of management and they're referred for an orthopaedic opinion, the first thing is to try to determine that the pain is coming from the hip. There can be crossover between the spine and the hip in terms of the distribution of their pain. In that instance, an intra-articular injection is a useful diagnostic tool to try and pick apart where the pain is coming from. It has the added benefit of being therapeutic, and that in a certain proportion of patients their pain will cease completely. If a patient gets transient benefit from an intra-articular injection, then they may be candidates for surgery. The surgical approach can either be arthroscopic or open surgery, the aim of which is to repair or remove the damaged structures within the hip and remove the causative deformity. So remove the cam off the femur or remove the pincer lesion off the acetabulum. Whether to proceed with open or arthroscopic surgery is dependent on the size of the deformity. The treatment is the same regardless. It's generally day case surgery, but the recovery can be quite prolonged, typically over a period of 6 weeks to 2 months. The most common cause for arthritis, hip arthritis in patients in general is idiopathic. In other words, we never really find a reason for it. But in those younger patients who develop arthritis, there's almost always a reason for it. The most common reason is a history of pediatric hip disease, such as developmental hip dysplasia, Perthes disease, or slipped upper femoral epiphysis. In those patients, they have a deformity either of their femur or their acetabulum that predisposes to early wear of their hips. Femoral acetabular impingement is emerging as another cause of early hip arthritis, and when untreated can lead to hip replacement in patients in even their 20s or their 30s. The typical life expectancy for someone who's had a hip replacement over the age of 65, they have a 95% of it lasting the rest of their life, or 20 years. The younger you get, the faster they wear out. In those patients who have a hip replacement under the age of 20, there's an 80% chance it'll last 10 years. The more active they are, the more they wear it out, the more likely they are to require a revision operation. Every revision operation gets more complex and the risks get higher. The principal risk of which I would be concerned would be infection. If a patient gets a deep-seated infection, the end result could be that they end up with no hip. Hence, we try to avoid hip replacement for as long as possible to reduce the risk of complications in the later stage. In terms of the non-operative modalities, the mainstay is weight control and exercise. Those are the two things that have been shown to make a difference to arthritis over any other intervention. Intra-articular injections have a role more so in knee arthritis than hip arthritis. The risk with hip arthritis, because the groin is a relatively dirty area, is that you can introduce infection into the joint. But there are various formulations of injections that can be given into the joint, such as local anesthetic and steroid or hyaluronic acid. There are a range of surgeries that can be considered in the appropriate patients. They're labelled non-arthroplasty hip surgery. The aim of those surgeries is to correct whatever deformity is predisposing the patient to hip arthritis. In the case of residual hip dysplasia, it would be reasonable to consider a pelvic osteotomy. In the case of Perthes or SUFI, it would be possible to correct the deformity of the femoral head that has been left by those conditions. In the case of femoral acetabular impingement, it's reasonable to consider either open or arthroscopic surgery to address that problem. I suppose the first thing is just in relation to the history. The typical feature of femoral acetabular impingement is the C sign, where the patient discusses a deep-seated pain in their hip and they place their thumb and index finger on the front and side of their hip respectively. That is one of the more specific signs for hip pathology. If that pain is starting to interfere with their activities of daily living, well then they have a pathology that probably warrants further investigation. In relation to the clinical examination, the key finding in early hip pathology would be pain on flexion, adduction and internal rotation, or the fader sign. Some of the more subtle signs might be a leg length discrepancy, which can be indicative of pediatric hip disease that they weren't aware of. Or alternatively, the patients might have scars about their hip. They aren't sure that they've had surgery because it was back in their early childhood, but that could be a sign of underlying hip pathology.